Hi, I'm Dr. Chris Lewis. I'm one of the chief educators here at Doctors in Training. This opioid lecture comes with a warning. It will be the best lecture you have ever witnessed. It may just ruin your enjoyment of future lectures. Never will you be able to love another lecture again. You may even have withdrawal symptoms after watching it. Prepare yourselves for euphoria. So let's get started. Most of the medications we're discussing today are used to alleviate pain. Now, what is pain? Well, we all know what it is, but it's been described as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Now, a lot of our research and subsequent recommendations regarding the use of opioids has stemmed from cancer research. So cancer patients have a lot of pain, it's continuous pain, and can even be resistant to a lot of the great medications that we have. Now, the World Health Organization, or WHO, has come up with a ladder, a pain medication ladder that goes along with severity of pain. So let's talk about that real briefly here. Now, mild pain, things that fall within the scale, we use this 1 to 10 scale of, 0 being no pain and 10 being the worst pain you can possibly imagine. Mild pain, somewhere between 0 and maybe 3 or 4. Now, some of this is rather subjective depending on the patient and how tough or not so tough they are. But mild pain, we usually try to stick with medications like non-opioid meds. So this includes things like acetaminophen, non-steroidal anti-inflammatory drugs. And this can be plus or minus some of the adjuvant medications, and I'll talk about those here in just a little bit as well. Now for moderate pain, now on this pain scale, this might be somewhere between 4, 5, and maybe upwards to 7. That might be kind of the higher end of moderate pain. And this is when we start to use these opioid medications. But some of the medications we use in these categories are maybe some of the less potent, things like codeine or tramadol, and we'll talk about these obviously here in a minute. Now, you can also add on the non-opioid medications, your NSAIDs, your acetaminophen, and then again you can add on these adjuvant medications as well. Now, severe pain, so this is the top of the ladder. Things in the 7 to 10 category when you're asking people to rate their pain. So this is where we're going to use our stronger opioid medications. So this would include morphine or fentanyl, and we've got a lot of other medications that we'll talk about that fit this category. And again, you can add on the non-steroidal anti-inflammatories, you can add on acetaminophen, and oftentimes these medicines are actually added into these opioid medications as combo pills. And then you can add on the adjuvants as well. So I've talked about the adjuvant medications. What are they? And we're not going to talk about these. This is the only place in the lecture we'll talk about the adjuvant medications, but it is important with our pain control that we try to come at it from a lot of different angles. So adjuvants, so antidepressant medications. Now there's been some great benefits from these medications, especially with people with chronic, unrelenting pain. Things like tricyclic antidepressant medications have been found to be valuable. SNRIs, or serotonin norepinephrine reuptake inhibitors. These medications have shown some benefit for long-term chronic pain. Muscle relaxers can be very helpful, especially with our musculoskeletal type pain. So things like cyclobenzaprine is a commonly used muscle relaxer, and there's several others. Benzodiazepines can also be used as muscle relaxers. They have good relaxation properties. And then finally, some of the anticonvulsant medications can be used as adjuvant therapy. Now, most of the time, this is, again, for chronic, unrelenting pain or even neuropathic pain. Say you have a diabetic patient that has diabetic peripheral neuropathy. Well, medications like gabapentin or pregabalin are medications that we try to use for long-term pain that we're not real optimistic about treating. So to further understand pain, to further understand how these medications work, we're going to talk about opioid receptors. Now there's 3 major receptor families. There's mu, there's kappa, and there's delta. Now there's also 3 major endogenous opioid peptides. So these are natural entities in the body that activate these opioid receptors. So we do have some ability endogenously to decrease pain in our bodies. So these include endorphin, dynorphin, and enkephalin. Now, They're all activated. All these will activate the different receptors, but there does seem to be a kind of a linkage here. Now, the mu is mostly associated with endorphin, and you often hear about people's endorphins getting up and not feeling as much pain. Well, that's a real thing. So endorphin can bind with mu receptors and can be very beneficial. Kappa is more closely associated with dynorphin, and delta is more closely associated with enkephalin. Next, the mu receptor is associated mostly with analgesia. So the other two are important, but mu is what you need to remember for analgesia. But it's also responsible for respiratory depression, sedation, euphoria, much like what you're feeling right now during this lecture, decreased GI transit, and physical dependence. Now, the kappa, we know, contributes to analgesia, and it also helps contribute to sedation and miosis, the pinpoint pupils that we'll talk about here in a little bit. Delta is a bit more uncertain, but we think it still contributes some to analgesia as well. Now, opioid receptors are located throughout the central nervous system, and they are out there, again, to help control pain, even endogenously. So, where do we find these things? So the medial thalamus will help mediate deep pain, and it's poorly localized. So that's one place where you see a lot of these mu receptors. You'll also find them in the spinal cord. So receptors in the substantia gelatinosa definitely have significant input on transmitting that pain from the periphery up into the brain. And then it also works in the periphery. So there are receptors out in the periphery that actually help decrease inflammatory factors like substance P. And substance P has been known to upregulate pain perception. Let's talk a little bit about the mechanism of action of these opioid receptors. How do they actually work biochemically? So these are part of the G protein family. In G proteins, you'll see very commonly within our autonomic nervous system and throughout the nervous system in general. So there's two well-established actions. So first, the receptors will close voltage-gated calcium channels, remember that, calcium channels, on presynaptic nerves. So presynaptic calcium channels, they're closing off these channels, and this will help reduce transmitter release. So it's preventing that transmitter from going out and stimulating the postsynaptic site. But it also works at the postsynaptic site as well. So they hyperpolarize and they inhibit that postsynaptic neuron by opening potassium channels. So remember, potassium channels on the postsynaptic neuron. So let's get to the meat of this lecture. Let's talk about the drug. Let's talk about these opioid agonists. History. So opioids are some of the oldest known drugs, and they're derived from the opium poppy. Now, there's images of opium poppies in ancient Sumerian artifacts. So 4000 BC, we're seeing evidence that people knew about opium poppies. China and the British Empire fought the Opium Wars between 1830 and 1860 when the Chinese attempted to stop the sale of opium by the British in China. Many modern writers have written about opium. If you can remember, even in The Wizard of Oz, Dorothy falls asleep in the poppy field. Opium poppies, the flower and the fruit, actually appear on the coat of arms of the Royal College of Anesthesia. And even today, it's a big deal because 60 to 70% of the economy of parts of southern Afghanistan are still very reliant on the farming of opium. And there's this great dilemma going on how we should affect that because, if we want Afghanistan to be more stable, then they need a better economy. But if most of their economy is due to producing opium, then that's not such a good thing. So now there's some classifications for the opioids, and some of them can kind of vary. Some of them, sometimes they like to categorize them as natural versus synthetic versus semi-synthetic. And our natural opiates include morphine and codeine. The semi-synthetic opioids include hydromorphone, hydrocodone, oxycodone, and heroin. And then there's some fully synthetic versions of opioids like fentanyl and tramadol, and propoxyphene. Now, they're also classified as full agonists or very strong agonists or partial agonists, and even we'll talk about some antagonists here in a little bit as well. So let's move on to the prototypical opioid. This will be the main part of our lecture today because opioids don't vary dramatically, though we will talk about the differences. But let's talk about morphine. This is the full agonist. This is the strong opioid, though not the strongest, but it's still the most commonly used opioid, and it's very important. So it was discovered in 1804 and was sold by Merck in 1827. So it's been around for a very long time. Its name comes from the Greek god of dreams, Morpheus. So let's talk about its mechanism of action. So morphine is primarily a mu receptor agonist, and that's why it works, because we talked about before how mu was mainly responsible for analgesia. So it also acts on the kappa and the delta receptors, and this is also associated with some analgesia, and it also helps promote meiosis, or the pinpoint pupils that we'll talk about here in a little bit. So it causes decreased neurotransmitter release through hyperpolarization of the nerve cells, and we talked about that before on the presynaptic and the postsynaptic. And where was the pre? What did we do there? We closed calcium channels. And what did we do on the postsynaptic? We affected potassium channels. So it also affects these kappa receptors, and the kappa receptors are often found in the dorsal horn of the spinal cord. And this is important in helping to decrease that transmittance of pain from the periphery through the spinal cord up to the brain. Now there's also a decrease in release of substance P, which we talked about a little bit before, and again, that helps modulate the pain perception in the spinal cord as well. And then it also inhibits the release of many excitatory transmitters from the nerve terminals carrying nociceptive or painful stimuli. So overall, we're getting this blockage of information from the periphery back to the brain. Let's talk about the major actions of morphine. So number one, analgesia, the most important thing about this med. So it can reduce pain without a major loss of consciousness unless you get to very high levels of medication. It can affect the sensation of pain at the level of the spinal cord, but it also affects the brain's perception of pain. So patients are often still aware of pain, but it's no longer an unpleasant sensation. That's kind of a hard thing to figure out unless you've actually experienced it before. It's like, well, yeah, I kind of know that that's not right, but yeah, it doesn't really bother me. It's not uncomfortable for me. Next is euphoria. Again, a lot like what we're experiencing right now, right? Similar feelings of euphoria through a lot of the opioids, but morphine is still sort of the prototypical, and you do feel quite a bit of euphoria with it. Patients will experience sort of a pleasant floating sensation, and they'll have lessened anxiety, and distress will kind of float away, and they won't have any major concerns while they're on the medication. Occasionally, people do have dysphoria, though. So you'll have some people who really don't like the way they feel when they're on morphine or other opioids. Sedation is a big deal. So you can get drowsiness, and you can have altered mental status. Now, this all comes with little to no amnesia. So we talk about some medications, especially when we're talking about medications associated with anesthesia that are good at kind of making you sleepy and drowsy, and then you don't really remember what's been going on. Well, this is not the case with the opioids, not the case with morphine. So you don't get a lot of amnesia with these medications. Now, you can induce sleep, but this tends to be a little bit more common with the elderly and people who are more sensitive to the medication. So here's a big one. How does it affect our respiratory system? So there's respiratory depression, and this can occur by inhibiting the brainstem respiratory mechanism. So there's a decrease in sensitivity to carbon dioxide. So most of the time when we're breathing, say if we hold our breath, well, there's sensors in the brain that says too much carbon dioxide. You need to start breathing or you're going to die. Well, when you're on morphine, that sensitivity goes down. So more CO2 builds up and you're like, yeah, I'm doing okay. And this can get bad. So this eventually, if you take a high enough dose of morphine, you can get respiratory cessation altogether. And this is a leading cause of death in overdoses. Next is cough suppression. So these receptors appear to be sort of different than some of the analgesia receptors. So we're not entirely sure what's being affected that's causing the cough suppression, but it's a very common effect of many of these opioids. And we'll talk a little bit more about that later on some of the specific cough suppressants. Meiosis, so pinpoint pupils. And this results from stimulation of mu and especially kappa receptors. And excites the Edinger-Westphal nucleus of the oculomotor nerve. And this causes an enhanced parasympathetic stimulation to the eye. Now this can be very valuable because you can have lots of people coming into your office, hopefully not your office, probably coming into the ER who are altered, who are having a difficult time being aroused. Now there's a lot of different things that can cause comas and respiratory depression, but a lot of the other things that can cause that problem, you'll have pupillary dilation. So if you have someone who comes in and they are zonked out and they've got itty bitty pupils, then the first thing that should really come to mind is, well, this person is on opioids and we need to pay attention to that and see what we need to do. Next is truncal rigidity. So this is an interesting phenomenon that can happen. So you can get this intensification of tone in the large trunk muscles, and this can interfere with ventilation. And this can be reversed with opioid antagonists, but this will also reverse the analgesic effect. So this can be really scary. So if someone comes in, they're already having depression of their respiratory symptoms, they're knocked out, and then you go to try to bag them, and their chest wall is not moving. And it can be a scary, scary thing, and you have to sort of weigh the risks and benefits of reversing that opioid effect. And it really depends on the situation on whether or not you're trying to induce anesthesia or if it's someone who's just coming in altered. Next, nausea and vomiting. This is a very common problem with the opioids. A lot of people don't tolerate the opioids because it makes them sick. The opioids can activate the brainstem chemoreceptor trigger zone. So this is a common area of the brain that's responsible for nausea and vomiting. Next, it can affect our temperature. So the mu receptor agonist can cause hyperthermia, and the kappa agonists tend to cause more hypothermia. And some of this can kind of flip-flop depending on withdrawal symptoms as well. And we'll talk about that a little bit later as well. Next, cardiovascular. And this will differ between the opioid agonists as well. So we'll talk about this in some of our other medications. But with morphine, so you can get high doses, can actually lead to hypotension and bradycardia. Now, with respiratory depression and increased levels of carbon dioxide or CO2, you can get vasodilation of the cerebral arteries. And this can lead to an increase in intracranial pressure. So that can be a big, big deal because morphine is contraindicated in patients with severe brain injury. So if someone comes in with a brain injury, you do not want to give them morphine because you might increase that pressure. Gastrointestinal. So this is another big and very common problem. So you can get decreased motility, an increased tone of the intestinal circular smooth muscle. So this leads to constipation. So it's very, very common, and it doesn't diminish with continued use. Now, it can be helpful when you're treating diarrhea or dysentery, but if you're putting patients on medications like opioids, you have to expect and at least warn them of potential constipation problems. Next, how does it affect the biliary tract? Well, opioids can contract biliary smooth muscle, and this can result in biliary colic, so you can get pain in your right upper quadrant. The sphincter of Oddi may also constrict, and this can result in a reflux of biliary and pancreatic secretions, and this can lead to elevated plasma amylase and lipase levels. Now, this is also important, more historically, but it's still used today, of why we don't use morphine in pancreatitis patients, because we're worried about closing off that sphincter of Oddi and making pancreatitis worse. So this is one reason why historically we've used meperidine, and we'll talk about that more specifically a little bit later in the lecture. So meperidine has its own problems as well. And you'll still see a lot of physicians still rely on meperidine or other non-morphine opioids to help control pancreatitis-associated pain. But it's also good to know that there's never been a good study that actually showed that morphine worsened pancreatitis or caused significant worsening of lipase or amylase in a pancreatitis patient. Next, let's move on to renal. So renal function is mildly depressed when given opioids, and this is believed to be due to a decrease in renal plasma flow. Now, the mu receptors have been found to have an antidiuretic effect, and there's also a ureteral and bladder tone increase, so you get more contraction of those muscles in the bladder and the ureter. And you can also have an increase in sphincter tone, and this can lead to urinary retention. So it's very, very common that a patient after surgery who's getting opioids to help control their pain from incision will have a urinary retention. So you have to always wait for someone to pee before they can go home after the procedure, even if it's a real mild procedure. How does it affect the uterus? Well, it can prolong labor by reducing uterine tone. So that's why you have to be careful with certain opioids during labor, because if you give it to them, then you can prolong that labor and even lead to potential complications of prolonged labor. Hormonally, there's some effects as well. These are a little bit more nebulous, but you can decrease gonadotropin-releasing hormone, and you can decrease corticotropin-releasing hormone, as well as LH, or luteinizing hormone, FSH, follicle-stimulating hormone, or ACTH. And you can also get increased growth hormone, prolactin, and ADH, antidiuretic hormone. So again, we talked about how the mu receptors had a little antidiuretic tendency anyway. Now you can actually get increased ADH that can cause to more urinary retention. And finally, pruritus. So histamine is often released from mast cells while taking an opioid agonist. And this can cause urticaria, sweating, vasodilation, so the typical almost allergic reaction phenomena. And this can lead to bronchoconstriction and should always be used very cautiously in asthmatics. So if you have an uncontrolled asthmatic patient or someone who has chronic obstructive pulmonary disease, you always need to be aware of that potential of bronchoconstriction with the use of opioid medication. All right, let's move on to some clinical uses of our opioid agonists. So, number one, obviously, analgesia. That's what these medicines are for. So, it's mostly reserved for the moderate to severe pain, though some of the partial agonists or wimpier opioids can be used for more mild pain. Another one is acute pulmonary edema, and this one's a little bit interesting. So intravenous morphine can produce a relief from pulmonary edema. Now, we're not really sure why. Now, it's usually pulmonary edema that's associated with left ventricular heart failure. And this might be due to sort of reduced anxiety and this perception of shortness of breath that can go along with this pulmonary edema. Now, it can also show some reduced cardiac preload and maybe some reduced afterload. But you got to be careful, because remember how we talked about how the opioids can actually cause some fluid retention. So you don't want to lead to more fluid accumulation. So certainly when someone's having acute pulmonary edema, usually some diuretics are being used as well. But that morphine can be dramatic. It can really help people feel like they're opening up their airways. Other clinical uses, cough suppression. So it can be obtained at lower doses of opioid than are needed for the actual analgesia effect. So the cough suppression opioids tend not to cause a lot of analgesia, but if you take enough of it, then obviously you're going to get that analgesia. And then finally, diarrhea. So diarrhea from almost any cause can be controlled with opioid analgesics. Now, there are some synthetics like loperamide and diphenoxylate that are used more often, and we'll talk about those towards the end of the lecture. Next, let's move on to pharmacokinetics. Now, for morphine, absorption from the GI tract is slow and a little bit erratic. And there's also, very importantly, first-pass metabolism that occurs in the liver. And that can decrease the percentage of usable drug that gets through and can affect the rest of the body. Now, there's IM, sub-Q, IV injections that can be used, and they're a bit more reliable because you're not going to get that first-pass metabolism that you're going to get with your oral meds. Now, when it is given orally, morphine is generally given in an extended release form. And this is specifically for morphine, and we'll talk a little bit about oral forms of other opioids that are a bit more reliable as well. Now, you can also inject directly into the spinal cord, and that can effectively make a very potent regional anesthesia and analgesia. And then you can also give this as a patient-controlled analgesia, or what we call a PCA pump. So oftentimes post-operatively, you'll give patients their own ability to control their pain medicine. So they'll get a little pump and a little button, and whenever they feel like they need the medication, they can push the button. Now, the nice thing is they can't just sit there and push the button and have a good old time and kill themselves. It actually locks out after a while. But you would think it would be a problem, but actually studies have shown that patients use less medication when they're on the PCA pump than when they're getting it scheduled. So it can be a great thing to give people a PCA pump because you're going to have fewer side effects as a result of those medications because they're going to use less of it. Now, it distributes well into all the tissues. It does pass through the placenta, so you got to be careful. And most of the time, we don't want to give this to pregnant people. Now, only a small percentage crosses the blood-brain barrier. Now, this is just for morphine that we're talking about right now. It's the least lipophilic of all the opioids, and we'll talk about more lipophilic opioids here in a little bit as well. It's conjugated in the liver and metabolized, and it's excreted in the urine. The duration of action for morphine is about 4 to 6 hours. And this will go for all of the opioids, but elderly patients are more sensitive to these medications, and some of this is due to decreased metabolism in the liver, and some of it is due to decreased renal function as well. So let's talk about the adverse effects, because there's quite a few of them, and we've talked about some of them already. Number one, constipation. Sometimes this can be severe, leading to fecal impactions that need specific treatment to get people unstuck. Oftentimes we will give patients stool softeners, especially after surgery or when we're prescribing for specific pains. And this will help alleviate, but you still got to be very careful with these medications because it can be a big deal. And you also, because of constipation, you don't want a lot of straining post-operatively because you might rupture sutures and that sort of thing. So that's another reason why we want to maintain a nice, steady, easygoing bowel movement schedule. Respiratory depression, we talked about this before. Overdoses can lead to death, and it can be rather dramatic. People can come in very altered and barely breathing, and they've taken too many opioids. Increased intracranial pressure, and we discussed the mechanism behind that earlier. So don't give it to your brain-damaged patients. Any brain injuries, you want to stay away from morphine. Urinary retention, another big deal. Again, we talked about this post-operatively. Patients won't pee for a while, and that can be due to the medication. Meiosis, or the pinpoint pupils, very important, very testable. You're going to have a question somewhere in your test somewhere that talks about someone who's altered and they've got little bitty pupils. So think opioids with meiosis. So next, let's talk about tolerance. So it begins with the first dose. But generally, this doesn't become clinically significant for about 2 or 3 weeks, and this is with frequent use. So you need more and more of the drug to achieve the same effect, and it keeps building up and building up. Now, one interesting thing about the tolerance is that meiosis and constipation do not develop any of this tolerance. So you would think after you take these medications for a long time and they don't affect you as much, you wouldn't get as much meiosis or constipation, but that's not the case. So you will still have constipation, you will still have meiosis, even with long-term continued use of the opioids. So next we're talking about physical dependence. And again, this is related to the mu receptor. So the mu receptor is great for analgesia, but it's not helping us a whole lot in regards to addiction. So after a person has taken opioids chronically and then abruptly stops, you'll start to get withdrawal symptoms. And this usually begins somewhere between 6 and 10 hours after the last dose. So we see some early symptoms and we see some late symptoms. So early symptoms that start somewhere between 8 hours and 24 hours, you're going to get things like anxiety and agitation. You'll get a lot of drug craving. You'll get a runny nose. You'll get a lot of rhinorrhea. You'll get lacrimation. You'll start crying. Diaphoresis, yawning. That's an interesting one. You see someone coming in, they're just yawning up a storm even though they're really anxious. Insomnia, and that might lead to the yawning as well because they can't sleep. and then mydriasis. So their pupils are blasted way big wide. So you will see people in your clinic and they'll come in looking really anxious, and you'll look into their eyes and they have huge pupils, and you'll go, aha, I know why you're here today. But let's talk about the late symptoms. So the 24 to 72 hours, how are we feeling? Well, it's getting a little worse. You're getting chills, you're getting piloerection, which always sounds really dirty, but it just means goosebumps. And then you can get hyperthermia, hyperventilation, hypertension, lots of hypers, tachycardia, mydriasis, remember you're still getting those gigantic pupils, myalgias, muscle spasms, tremors, abdominal cramping, nausea, vomiting, diarrhea. Obviously, after all this, people start to get a little hostile, so you can see some hostility. And then ultimately, and rarely, you can see seizures. Now, withdrawal is very distressing to the patient, but it's rarely life-threatening. So it's much better to have to withdraw off of morphine than it is to withdraw off of, say, alcohol. Alcohol withdrawal can kill you, where opioid withdrawal generally won't kill you. And occasionally it can, but not usually. So supportive measures are usually all that are needed. Now, you can use a few medications to help alleviate some of the symptoms. Things like clonidine can help reduce anxiety and muscle aches and some of the sweating and the runny nose. Antiemetics can be used to help with the nausea and the vomiting. And antidiarrheals can also be used, though you probably don't want to use a lot of opioids because you're trying to get people off of these medications anyway. So what happens with overdose? Well, you're not going to see a whole lot of movement out of these people. You're going to see a semi-comatose or a fully comatose state. You're going to see respiratory depression, so they're not breathing a whole lot. And remember, if you see a patient in this condition, they're unresponsive, and they have pinpoint pupils, they got these little bitty pupils, there's a good chance that they're under the influence of opioids and they've overdosed to some extent. So what do we need to do? Well, we need to support them. We need to make sure they don't die. So the first thing they need is oxygen. So sometimes you have to intubate these patients. They're not breathing well. You need to protect that airway. So that's the first thing. You want to maintain their fluid status. So you're not exactly sure what's causing this state, but you always want to put an IV in them, make sure that they're well hydrated. Now, and we'll talk about this in more detail later, but you can give them a reversing opioid agent. So something like naloxone or naltrexone. And we'll talk about that, and that'll bring people out just like that. And anyone who comes in altered and you don't know why, oftentimes we'll give these type of medications just preemptively and see if they pop right out of it. Now, drug interactions. So these opioids are CNS depressants. So anything else that's a CNS depressant can add on to these medications and make them act even more severely. So sedative hypnotics, benzodiazepines, those type of things, they can increase that CNS depression and respiratory depression. The actions of morphine are enhanced by monoamine oxidase inhibitors and phenothiazines and tricyclic antidepressants. But in general, if something else is making you sleepy and they're also on morphine, you're just going to get even more sleepiness and more respiratory depression.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
All right. I'm in an unusually foul mood today, so don't disappoint me. What are the major actions of morphine? I hate to think about all the money your parents are wasting sending you to medical school. They might as well just be flushing fistfuls of cash down the toilet. It would accomplish the same thing. Morphine causes analgesia, euphoria, respiratory depression, constipation, meiosis, just to name a few.
Hi, I'm Dr. Mike McInnes. I'm one of the chief educators here at Doctors in Training. And let's go over quick review number 1. A 43-year-old female with depression complains of diffuse daily musculoskeletal pain. She has multiple tender points throughout her body. Her pain is not severe enough to warrant an opioid pain reliever. What other medications might be helpful? This patient's symptoms are consistent with fibromyalgia. It's a condition of increased pain, increased sensitivity to pain. They hurt all over. It's very commonly associated with depression, multiple tender trigger points. So this is fibromyalgia. So you typically don't want to put these patients on opioids. They're going to have pain long term. They're going to become addicted to the opioids. They're going to become tolerant to the opioids and need stronger and stronger doses. So try to avoid opioids in your fibromyalgia patients. Sometimes it's difficult, but you really should just be firm and say no when they start asking for hydrocodone and some of these narcotic pain medications. So you want to use a non-narcotic pain medication. You can use a serotonin norepinephrine reuptake inhibitor such as duloxetine or venlafaxine. You can use a tricyclic antidepressant, although again these drugs are a little less safe, not because they're addictive, but because they are potentially toxic and overdose. And you can also use certain anticonvulsants, not any anticonvulsants, but specific anticonvulsants such as pregabalin. So there are lots of drugs you can use to help reduce the pain of fibromyalgia without using an opioid. Next question, what are the effects of the mu receptor activation? Well, you can get analgesia. That's the most common reason we would use an opioid. So analgesia is a mu receptor effect. You also get respiratory depression. So that's not what you're aiming for, but that's often a side effect of using opioids. Respiratory depression, sedation, euphoria, decreased GI transit or slow GI transit time, and physical dependence on opioids obviously is a big problem. Next question, how does morphine affect the respiratory system? Well, morphine causes respiratory depression because it decreases sensitivity to CO2. Respiratory depression is a leading cause of death in overdoses of morphine. Next question, a 56-year-old man presents to the emergency room. He suffered an MI while driving, which led to a motor vehicle accident in which he sustained a closed head injury. Because of his MI, he now has left ventricular heart failure and pulmonary edema. Which of his problems is an absolute contraindication to opioid use? Well, he's got several problems here. He's had an MI, he's had a closed head injury, he's got left ventricular heart failure and pulmonary edema. So the contraindication among these to opioid use is the closed head injury. Remember, morphine is commonly used in MI to reduce myocardial oxygen demand, and it can be used to treat pulmonary edema as well. So the answer we're looking for is a closed head injury. Respiratory depression leads to rising CO2, as we mentioned, and this causes cerebral vasodilation and can cause elevated intracranial pressure. So closed head injury is a contraindication to use of morphine. Next question, besides analgesia, what are some clinical uses for morphine? So we mentioned analgesia is the main reason to use morphine, but what else can you use it for? Well, you can use it to treat acute pulmonary edema, as we just mentioned. You can use it to relieve cough, although it's kind of overkill, but if you've got somebody with a severe cough, morphine will suppress that cough. You can also use it to treat diarrhea because, as we said, activation of mu receptors will slow GI transit time. You can actually cause constipation with morphine. So sometimes if you have a patient with severe diarrhea, you really need to stop it, you can use morphine, although again, that's kind of overkill. Next question, how does morphine help patients with pulmonary edema? Okay, we've mentioned this a couple of times. So in pulmonary edema, shortness of breath may improve due to reduced anxiety and perception of shortness of breath. So just like patients on morphine will be aware of pain but not really care, they may be aware of shortness of breath but they don't really care as much, so they're not as anxious about it. They're not freaked out about the fact that they can't breathe, so the shortness of breath may actually improve as they become less anxious. And also, morphine may cause a mild reduction in cardiac preload and afterload, and that may reduce the pulmonary edema. The last question, a 26-year-old male presents 48 hours after his last dose of heroin. He's experiencing severe withdrawal symptoms including anxiety, muscle aches, tachycardia, vomiting, diarrhea, and hypertension. So these are all symptoms of heroin withdrawal or opioid withdrawal. How should you treat this patient? Well, the main thing is supportive measures. You want to monitor airway, breathing, circulation, and so forth. You can use clonidine, which will help reduce anxiety, and it'll also help reduce muscle aches and sweating. You can use antiemetic drugs to help with the nausea and vomiting, and you can use antidiarrheals to help with the diarrhea. So again, these are basically supportive measures to help the patient as they withdraw from the narcotic. So that's it for our quick review. Let's get back to Dr. Lewis.
Let's move on to another medication. Let's talk about meperidine. This is also called Demerol. Now, it's a synthetic opioid. It's also a strong or full agonist. And it's very similar to morphine in a lot of ways. It binds to the mu and kappa receptors. You can still get very similar respiratory depression. But one big difference is that there's no significant cardiovascular action. Remember, the morphine has some potential problems. It can cause you some hypotension, some bradycardia. It can affect your intracranial pressure as well. The meperidine doesn't affect it quite as much. Another big one is dilation of pupils. So this is due to an atropine-like action. We just talked ad nauseum about these pinpoint pupils, and now I'm telling you that meperidine can cause dilated pupils. But it's really the only opioid out of all these that can cause the dilation. You get less urinary retention. You get less effect on uterine smooth muscle, and sometimes we'll use this more in labor and delivery. It's not clinically useful for diarrhea or cough. Some of the other ones are real good for that, but not for this one. And you get less effect on the sphincter of Oddi. So remember how we talked about pancreatitis, and the morphine theoretically can clamp down on that sphincter and cause a kind of regurge of secretions back into the pancreas and cause an increase in amylase and lipase. Again, this is more historical. There's no great data that shows that morphine can actually cause any problems, but you're going to get pimped on that somewhere with a pancreatic patient. You're going to have someone ask you, why don't you want to use morphine in pancreatic patients? And you'll throw back right at them, sphincter of Oddi constriction. So keep that in mind. Therapeutic use, analgesia. So pretty simple. Very similar to the reasons why you're going to use morphine, other than obviously the cough and the diarrhea. And then also because it's safer during labor, you will have people still use meperidine to help with labor pain. Pharmacokinetics, it's well absorbed from the GI, so it's a little bit better absorbed than it is than morphine, but it's still often given parenterally, especially in the ER or up on the wards. The duration is a little bit shorter. It's just 2 to 4 hours. It's metabolized in the liver and it's excreted in the urine as well. So let's move on to the adverse effects. So on the surface, this medication looks great. Meperidine seems fantastic. It gives you great analgesia. Maybe it doesn't work quite as long as morphine, but you get fewer side effects and fewer urinary retention. So, and you can use it during pancreatitis. So why don't we use this all the time? Well, and this is going to be great for testing. There's an accumulation of toxic metabolites, and it's called normeperidine. And this can lead to anxiety, tremors, muscle twitches, and even convulsions. And you have to be especially careful in renal patients. So if you're not clearing your meperidine, you can get a serious buildup of these toxic metabolites and cause some major CNS problems. So that's a great test question. You're going to hear about those toxic metabolites throughout your career. There's also some anti-muscarinic effects. So what are those? Blurred vision, dry mouth, real common with meperidine. Again, we talked about the pupillary dilation, and you also get some hyperactive reflexes, so be aware of that. And then you do get a little bit of hypotension, especially if you're giving this post-operatively. I know we talked about how there's not as many cardiovascular effects, but especially post-operatively, for some reason, you get a little bit more hypotension with meperidine. Next, we're going to move on to methadone. And its mechanism of action is, again, very similar to morphine. It works on mu receptors. Its actions, again, very similar. Analgesic effects are great, pretty much equal to morphine. And the other actions are also very similar to morphine. So when do we use these medications? Well, you can use it for analgesia, like every other opioid. But what's interesting about methadone is that it's often used for opioid abuse. And this can come as someone either taking morphine or other commercially available opioids, but it's often used for heroin. So heroin addicts, people trying to get off of heroin, and we'll talk specifically about heroin in a little bit. We use methadone. So why is methadone more suited to help get people off of opioids? Well, one, it has a longer half-life. So it's useful to give it once a day, and it can last most of the day. It also has less euphoria, and that's a big part of it. So people have less tendency to abuse methadone because it doesn't make you feel as good. So you can slowly wean patients off of the med over the span of weeks, and it can be very helpful for that. Now, there's better oral absorption than morphine, so that's another reason if you're going to use this as an outpatient detoxification drug, it's easier to give this orally than having to give it either IM or intravenously. And it's very reliable, so you get a good absorption. You're not going to get sort of the erratic effects or erratic absorption that you get with morphine. And the adverse effects are very similar to morphine, but you can still have addiction. If you take your methadone chronically, you're still going to be getting some euphoria, and you're still going to be having those mu receptors activated, and that's going to lead to some dependence and tolerance issues. Next is fentanyl. This is a little bit newer opioid, but very popular now. It's chemically related to meperidine, though it does have some very impressive differences as well. Now, it's 100 times more potent than morphine, so this thing's a bazooka. It is very, very potent. And it is highly lipophilic, and it has a rapid onset and a short duration. So it's very different than morphine in that regard. Remember, morphine does not get into to the brain quite as much because it's not as lipophilic. Well, this is highly lipophilic, rapid onset, rapid duration, short duration, and that's one of the reasons why it is so beneficial for things like anesthesia. So this can be used for induction of anesthesia. It's also used in an epidural form, and it can be used during labor to help decrease the pain of labor. There's a very popular transdermal patch, and this is popular for chronic pain syndrome. So a lot of pain specialists will use the fentanyl to give people a very consistent but long-term supply of pain medication. There's also a transmucosal form that's very rapid acting. Now, the adverse effects are very similar to morphine. It causes pupillary constriction. Remember how we talked about how meperidine had that dilation? Well, even though this is somewhat similar to meperidine, you're going to get that pupillary constriction rather than dilation. And it's highly addictive. So it gets into the brain quick, it gets out of the brain quick, and that always means high addictive potential. So these medications can be habit-forming, so you got to be really careful with them. There are some similar medications that we're not going to really go into much detail, but you should know their names. Sufentanil, alfentanil, remifentanil. These three are very similar to fentanyl. They have a little bit different half-lives, but overall they work pretty similar to the regular fentanyl. Next, heroin. Very, very popular drug, abused. It's produced by diacetylation of morphine, and it leads to about a 3-fold increase in potency. So this is more potent than morphine. Now, it has high lipid solubility and results in a high degree of euphoria when taking intravenously. And this accounts for its abuse. So remember the same thing with fentanyl. You're getting high levels of this medicine into the brain because it's very lipid-loving. Now, it only lasts about half as long as morphine, so that's another reason why it's more addictive. Now, heroin in and of itself is converted into morphine in the body. So when people are taking heroin, they're actually eventually getting to morphine after it's metabolized some. And it has no accepted medical uses. There's been some tries of using it medically, but overall it's still just a drug of abuse. Let's talk about hydromorphone. Again, action's very similar to morphine. It's about 4 or 5 times more potent than morphine. It's commonly used in PCA pumps. Remember we talked about those patient-controlled analgesia pumps, and they'll often use the hydromorphone for that. Now you have to be very, very careful about renal patients, and this can get you into big trouble with your PCA pumps. The usual half-life of hydromorphone, somewhere around 2 hours. Well, if you have a renal patient, someone who has poor creatinine, bad clearance, well, that 2 hours might turn to 40 hours really quick. And a patient with renal impairment can lead very quickly down to respiratory depression and coma. Next, we're going to move into some medications that are maybe a little less potent than what we've talked about before. We group some of these medications together in different categories. There's one category called phenanthrenes, and this includes codeine, oxycodone, and hydrocodone. And hydrocodone is also known as Vicodin. You'll hear that used quite often as a branded name. And these are what we call partial agonists, or maybe weaker opioids. Now, similar in action as morphine, somewhat less efficacious. They're orally taken more often than not. Sometimes they're formulated with aspirin or acetaminophen. Things like Vicodin will have acetaminophen in them, and you'll hear about Tylenol number 3 or Tylenol number 4, and that's Tylenol with codeine. Again, side effects are very similar to morphine. You're going to get your constipation still. You're still going to get your drowsiness and a lot of the other things that go along with it. Codeine is used very often as a cough suppressant, and the dose for cough suppression is less than what's needed for the analgesia effect. So you'll get less euphoria because you're really not getting into those high levels of mu stimulation. Now, hydrocodone is even more potent for cough suppression, but it also has better analgesia. So we tend to use more hydrocodone to help with mild to moderate pain. Oxycodone sometimes is still considered one of the strong agonists. It is it is a Schedule II medication, meaning that you can't just write it on a regular prescription pad, at least here in Texas. So sometimes it's considered a little bit stronger, and it's often abused by patients who crush the extended release version. So oxycodone can be given once or twice a day, and people just crush that up and then they'll get a pretty good high. But that can lead to more respiratory depression and has been the cause of death in patients over the years. Propoxyphene, also known as Darvon or Darvocet, and that's just propoxyphene with acetaminophen. Chemically related to methadone, but it has a low analgesic activity. It's about half as potent as codeine, and codeine isn't all that potent to begin with. There's less abuse potential, which is nice compared to the other opioids. It does have some potential cardiotoxicity and some increased seizure risk. And just recently, November of 2010, it was actually taken off the market. And it was taken off the market because of an increased risk of cardiac arrhythmias. It might be a little too soon for this to show up on tests, but eventually it will. And this is kind of scary. We've been using this medication for 25 years, and it's hard to know, what potential harm has been done by propoxyphene. So we're going to switch gears to something called the mixed agonist-antagonist. So drugs that stimulate one receptor but block another are termed mixed agonist-antagonists. And the effects of these drugs depend on the previous exposure to opioids. So in individuals who have not recently received opioids, or naive patients who haven't had opioids, the mixed agonist-antagonists show agonist activity, so meaning they're going to feel the typical opioid effects of these medications. So they're used to help relieve pain. So in patients with opioid dependence or long-term use of opioids, these medications may show a blocking effect. So they can actually induce withdrawal symptoms. So someone who's not on medications chronically, they'll feel the analgesia. It'll be a positive thing for them. If someone comes in and they've been taking opioids like crazy and they take these, it's going to block them and they're going to have potential withdrawal symptoms. So big deal. The first one we're going to talk about is pentazocine, and this is also called Talwin. So this is a kappa agonist and a weak antagonist at the mu receptor and also at the delta receptor. So agonist at kappa, weak antagonist at mu and delta. Now this promotes analgesia by activating receptors in the spinal cord. Remember how we talked about how kappa likes to sit in the spinal cord and block transmission there. Now it's used for moderate pain. There's less euphoria because you're not stimulating those mu receptors. And the adverse effects are still pretty similar to our other medications: respiratory depression, constipation. High doses can actually lead to elevated blood pressure, hallucinations and nightmares, dysphoria, and tachycardia. We're not using this medication all that often because of those side effects, though it is sometimes nice to have it around, especially if you're not sure if someone's drug seeking or not. Our next medication is buprenorphine, and this is a partial mu agonist and a kappa antagonist. Now it's given sublingually, which makes it a little bit novel, and it has a long duration. And it's sometimes used to help with detoxification and maintenance of heroin abusers. At high dosages, you will get mu receptor antagonism as well. So therefore, you're not going to get as much analgesia and less respiratory depression at the high doses, which is kind of nice. Next is a medication called nalbuphine, and this is also called Nubain. Now, it's a strong kappa agonist and a mu antagonist, and it's given intramuscularly, also given IV and sub-Q. There's less respiratory depression, but its long action can sometimes be problematic because if you do take enough of it and you get respiratory depression, things like naloxone or the other antagonists are resistant. So you're not going to be able to reverse them quite as easily as some of the opioids. Next is butorphanol or Stadol, and this is a kappa agonist and a mu antagonist. It's used a lot of times for labor pain because it causes less respiratory depression in the newborn. And this can be given intranasally as well for migraines. Now there's a category of analgesics kind of all by itself, and it's mainly made up of tramadol, and it's a weak mu receptor agonist. But they think that the main mechanism behind this is a blockade of serotonin and norepinephrine reuptake. And it's indicated for moderate pain and has very low abuse potential, which is really, really nice. It does not work as well as the other opioids. You'll have a lot of patients who don't want the tramadol because it just doesn't give them the punch that the other opioids do. There's less respiratory depression, which is really important. It is contraindicated in patients with seizure disorder. When it's combined with SSRIs or serotonin, selective serotonin reuptake inhibitors and the tricyclic antidepressants, you can increase that seizure threshold. Next, let's talk about the antagonists. So we mentioned these briefly before. Naloxone is the first one, and it's used to reverse the effects of opioids. Now, it's usually used when patients are coming in altered. They're coming in a comatose state. They have some respiratory depression, and we're thinking there's some overdose of opioid going on. Now, it blocks at mu, kappa, and delta, so you're getting all of them there. And it'll rapidly displace all the already receptor-bound opioid molecules. So even all those molecules are stuck on those receptors, well, those will just knock it off and very rapidly reverse that opioid stimulation. So it can work within about 30 seconds after IV injections. It can be really impressive. Someone's just sitting there going, ah, and then you give them the medication, they're up quick. Now it has a half-life of 60 minutes, sometimes up to 100 minutes. So patients who have maybe taken opioids with longer half-lives, they can relapse into that comatose state after that naloxone wears off. So oftentimes you'll have to redose that naloxone to help keep off that opioid stampede. Now, what's also interesting is that it'll precipitate withdrawal symptoms. So opioid abusers, once they're in their comatose state, they'll wake up, and then they're waking up and they're having symptoms. You know, they're going to have that sweating, they're going to have the anxiety and the hostility. They're not going to be real happy with you after you give them naloxone. They're going to feel pretty bad. Another medication that's very similar is called naltrexone, and this might be used maybe a little more often than naloxone. It has very similar actions, but it does have a longer half-life. The half-life is somewhere between 4 and 6 hours. So some of the longer-acting opioids aren't going to rebound back on you because this will still be blocking you 4 to 6 hours later. It's been said that even, especially with heroin users, that one dose of naltrexone it can help counteract heroin for somewhere like 48 hours. So it's a good preventative medication as well. Now, it's also been used to treat alcoholism. The mechanism isn't perfectly understood, but it can help alcoholics with their treatment programs. Adverse effects, it does have some hepatotoxicity that you have to watch out for, so check your LFTs afterwards after using this. Nalmefene is another medication, very similar to naloxone, but it has an even longer half-life, 8 to 10 hours. So that's its really only difference between the other ones. There's another medication called methyl naltrexone. Now this acts peripherally on mu receptors, so it's not affecting the central nervous system quite so much. So why would this be helpful? Well, it can help opioid-induced constipation. So it's not going to necessarily knock out that nice analgesia that's being affected in the central nervous system, but it's just going to help block this peripheral mu receptor response, so you'll get less constipation as a result of opioid activation. Now finally, we're going to talk about 3 medications. They're non-analgesic opioids. And the first group are used for diarrhea. So we have some anti-diarrheal agents. The first one is called loperamide. Now it acts on peripheral mu receptors as well. I mean, it doesn't cross the blood-brain barrier, so there's really no major abuse potential, and it can be a very helpful medication to decrease diarrhea. Diphenoxylate is another medication, and it can cross the blood-brain barrier, and at high dosages you can get euphoria and dependence. So how have we got around this problem and prevented people from abusing their anti-diarrhea medicine? Well, we've combined it with atropine. And if you try to take too much of the diphenoxylate, the atropine levels will get high enough and you'll get weak and you get nauseous and you won't feel very good. So it's a good way of preventing people from taking too much of that diphenoxylate and getting that happy euphoric feeling. And finally, dextromethorphan. So this is a cough suppressant. So it's an opioid agonist, but it has very, very low abuse potential. In fact, it's actually an over-the-counter medication. And it's often combined with other cold remedies like guaifenesin to help with cough and cold and congestion. It also works by working some NMDA receptors and has some mild anticholinergic effects. So you can get some adverse effects that include constipation and sedation.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide. All right, let's go over quick review number 2. First question, why is meperidine preferred over morphine to treat pain in patients with pancreatitis? So in pancreatitis you get intense abdominal pain. It's a very painful condition. You often will need to give an opioid analgesic. Classically, meperidine is preferred because meperidine will cause less contraction of the sphincter of Oddi. Now, there's little evidence that this is a clinically significant difference, meaning morphine may cause more sphincter of Oddi contraction, but that's not going to make the patient any worse. There are no good studies that have showed any worsening of pancreatitis due to morphine, but you will be pimped on this again and again and again. Why do we use meperidine or Demerol instead of morphine? The answer is meperidine causes less contraction of the sphincter of Oddi. So again, not clinically useful, but it will help you during your rotations, and even as an intern. You'll be asked that over and over again. Next question, what is the main cause for many of the adverse effects of meperidine? Well, there's a toxic metabolite of meperidine that builds up, and this toxic metabolite is called normeperidine. And so as this builds up with repeated dosing of meperidine, you can get adverse effects including anxiety, tremors, muscle twitches, and convulsions. Next question, when administered intravenously, what are the durations of action for the following medications? So the first one is morphine, which has a duration of action of about 4 hours. Then meperidine, which has a duration of action of 2 to 4 hours. And fentanyl, which has a duration of action of 15 to 30 minutes, which is why fentanyl is usually given as a transdermal patch if you're going to use it long term. Next question, a 22-year-old male with a heroin addiction presents wanting to quit his drug use. What medication would be helpful in breaking his addiction? Well, you probably know this even before you started medical school, and that's methadone. It's a good medication for addiction to opioids because you can give it orally, unlike morphine. It has good GI absorption. Also, it has a longer half-life than morphine, and therefore you have fewer withdrawal symptoms. And it will cause less euphoria. Next question, what properties of fentanyl make it a useful medication for anesthesia? Well, it's more potent than morphine. It's got a very strong analgesic effect, about 100 times more potent than morphine. And also, it's highly lipophilic, which means it has a rapid onset of action and a very short duration of action, as we mentioned. So you can give IV fentanyl during anesthesia. It's very useful for that. Next question, tramadol is contraindicated in patients with what type of disorder? Well, tramadol is contraindicated in patients with seizure disorders. Not an absolute contraindication, but definitely a relative contraindication. In a patient who has a history of seizures, you want to avoid tramadol if at all possible. Tramadol can lead to increased risk of seizure in overdose, but also in normal doses. And it also will increase the risk of seizure if you're giving a tricyclic antidepressant or an SSRI, a selective serotonin reuptake inhibitor. So there are some drugs, when combined with tramadol, will increase that propensity to seizures. So avoid tramadol in patients with seizures if you can. Next question. Atropine can be combined with what medication to reduce the CNS effects and dependence that can occur if taken alone? The drug here is diphenoxylate. The brand name of this is Lomodal, which is a combination of diphenoxylate and atropine. So if you're taking this drug in order to get high, so you're taking large doses of it because you want that opioid effect from the diphenoxylate, you're also going to get a large dose of atropine. Well, atropine is an anticholinergic drug, so you get lots of those anticholinergic side effects. You get nausea, dizziness, and other unpleasant side effects. So that's why we combine diphenoxylate with atropine for diarrhea. Next question. A 25-year-old female is requiring pain control during labor. What mixed agonist-antagonist type opioid would be most appropriate and why? The drug is butorphanol. Butorphanol causes less respiratory depression in the newborn, so it has that advantage in patients who are in labor. Butorphanol can also be used intranasally to treat migraines. Final question, what is one drawback of using the short-acting opioid antagonist naloxone? Well, if the patient is taking a long-acting opioid and you give them naloxone, that's going to bring them out. It's going to reverse that action on the opioid receptors and bring them out of their opioid-induced coma from overdose. But then the naloxone is going to wear off, but they've got this long-acting opioid on board. So they're going to relapse into coma after the naloxone wears off. So you need to be aware that naloxone has a relatively short duration of action. So if they're using a long-acting opioid, you may need to give naloxone several times to prevent the respiratory depression and coma and so forth. So that's the end of quick review number 2. Let's go ahead and take a moment to pause the video and complete the end of session quiz, and then we'll go over that together.
Miss, are you okay?
No.
I'm a doctor. Maybe I can help. It looks broken. There's nothing I can do from here.
Doctors, how many times has this happened to you? You're at the scene of an injury, but without any medical equipment, there's little that you can do. Well, now, there's an app for that. Leg might be broken. Here you are, doctor. Try our new X-ray app.
What? Your phone? Get the thing away from me. Just call an ambulance.
Incredible! It is broken!
That's a type 2 compound tibial fracture to be exact. She'll need surgical repair, and you'll need to monitor her closely for compartment syndrome.
Awesome!
Next, you can use our amazing Splint app to secure her leg.
Thank you, doctor.
Now we can use our app to assess the patient's pain levels and act accordingly. Does this hurt?
Ah!
Perfect. Now we can use our analgesic app. Opioids can cause constipation, hypotension, altered mental status, or respiratory depression, but not our app. Plus, there's no risk of dependence. We even have an app that allows you to signal for the closest ambulance.
Cool! How do I do that?
You already did. Remember, if you're a doctor on the go, there's an app for that.
All right, let's go over the answers to the end of session quiz. First question, which family of opioid receptors is the primary mediator of analgesia? We mentioned this several times. These are the mu receptors. Next question, list the main clinical use for each of the following drugs. So the first one is fentanyl. This is primarily used for analgesia. Remember, it's 100 times more potent analgesic than morphine is. B, dextromethorphan. This is primarily used as a cough suppressant. Naloxone is used to reverse acute opioid overdose. D, methylnaltrexone. This is used in the treatment of opioid-induced constipation. Remember, it acts on peripheral mu receptors, but not the central mu receptors. So it's not used so much for opioid overdose, but it can be used to treat opioid-induced constipation, which is a very big problem in patients who take opioids chronically for cancer pain and so forth. E, loperamide. This is an antidiarrheal. You may be aware of the over-the-counter brand Imodium. And then F, methadone. This is used to manage opioid dependence and sometimes used for analgesia, but usually it's used in the treatment of opioid dependence. Next question. Match the agents below with their action on opioid receptors. So we're going to match each of these drugs. Are they strong agonist, moderate and low agonist, antagonist, or mixed agonist and antagonist? So the first drug is alfentanil. This is a strong agonist. Hydrocodone is a moderate agonist. Oxycodone is another strong agonist. Nalmefene is an antagonist, an opioid antagonist. Meperidine is another strong agonist. Propoxyphene is a moderate and low agonist. Pentazocine is a mixed agonist-antagonist. And then heroin is a strong agonist. Next question. Match the following clinical descriptions with the most appropriate therapeutic agent. So we're going to choose from meperidine, methadone, tramadol, and naloxone. So A 31-year-old woman is in labor, in need of IV analgesia. Probably going to reach for meperidine for this patient. B, a neonate is born in respiratory depression secondary to his mother's opioid use. Well, you're going to use the opioid antagonist naloxone. Remember, it's very short-acting. C, a 28-year-old woman is in a treatment program for heroin addiction. We've said this a couple times. You use methadone to treat opioid addiction. And D, a 49-year-old man, recovering addict, needs a prescription for an analgesic. You're going to use tramadol because it's not going to have any abuse potential. Next question. Which moderate opioid analgesic is potentially cardiotoxic at high doses and has a higher risk for arrhythmias? Well, this is the drug propoxyphene, which blocks cardiac sodium channels like local anesthetics and the class 1 antiarrhythmics. This can cause arrhythmias and depressed heart rate, depressed myocardial contractility, and pulmonary edema. So this drug has been taken off the market. You'll still hear a lot about it. Patients have been using this for 30 or 40 years. They love the drug. They're hooked on the drug, but it's no longer available. Next question. Which opioid antagonist is the first-line drug for the treatment of acute opioid overdose? Well, again, this is naloxone. You might think, well, what if I use one of the other opioid antagonists, such as naltrexone or nalmefene? These are longer acting. They can be used for long-term management, but you're not going to use them for acute opioid overdose. You're going to use a short-acting drug such as naloxone. Next question. Describe the early and late symptoms of opioid withdrawal. So the early symptoms occur between 8 and 24 hours after the last opioid dose. These early symptoms include anxiety, agitation, drug craving, rhinorrhea or runny nose, lacrimation or tearing, diaphoresis or sweating, yawning, insomnia, and mydriasis or dilation of the pupils. And then the late symptoms occur anywhere from 24 to 72 hours after the last opioid dose, and these include chills, piloerection or the hair stand up on end, hyperthermia, hyperventilation, hypertension, tachycardia, mydriasis, again that dilation of the pupils, myalgias, muscle spasms, tremors, abdominal cramping, nausea and vomiting, diarrhea, hostility, and seizures. So pretty nasty stuff. Don't get hooked on opioids. Next question. What can you expect if you gave pentazocine to a patient taking morphine for inadequately controlled postoperative pain? So this patient's already getting morphine, and you say, I'm going to add something to it. I'm going to add pentazocine. Well, actually, this is going to make the pain worse. Pentazocine is a mixed agonist-antagonist. It will antagonize the effects of morphine on the mu receptors. So if you have a patient who has not been on any opioid or they're opioid naive, pentazocine is a great drug because it's going to act on those, it's a partial agonist on those mu receptors, but it's going to suppress pain in an opioid naive patient, but if you have a chronic opioid user and you give pentazocine, you're going to make things worse. Next question. Why are strong opioid agonists such as morphine particularly dangerous in patients with closed head injuries? We talked about this earlier. Morphine causes respiratory depression, which leads to CO2 retention. CO2 retention causes dilation of the cerebral vessels to improve cerebral perfusion. Dilation of cerebral vessels increases intracranial pressure, and this can be particularly dangerous in patients with a closed head injury because these injuries are associated with brain edema and elevated intracranial pressure. So if you increase intracranial pressure further via morphine, you can restrict cerebral blood flow. That's a bad thing. You need to perfuse the brain at all costs. Final question, which opioid antagonists are used to treat alcohol dependence? These include naltrexone and nalmefene. So these are the long-acting opioid antagonists that we mentioned earlier. They can be used to treat alcohol dependence. So that's the end of session quiz for your lecture on opioids. Thanks very much. I hope this was a pleasant experience. I'm probably not as euphoria generating as Dr. Lewis. I'm only a partial agonist.